So I'm going to do a case presentation today. And for those of you who have not presented a case, this is what the form will look like. So Mithra sends out a link and you just complete this form, and it's really informal. If you don't have some of the information, that's okay. I didn't put all of the information. So, we ask questions. It's just a discussion. Today, I have a PowerPoint with it. We do not expect that with case presentations, but just so that I didn't want to assume, we have so many different providers. I didn't want to assume that everybody knew how to go through a diagnostic criteria for infant mental health. So that's why I did the presentation at the end, so that we have an understanding of that and kind of where it came from this. But I would love to hear some of your perspectives on this case study. So some of the directions that you would have went into. So really we do the case consultation piece for cases that you are stuck with, or you might have just a couple different ideas and you just want to bounce it off of providers. And so, absolutely, provide those cases when you have them. So here's our case. I gave my little guy a pseudo name of Ben. So we're going to call him Ben today. But when he came to see me, he was actually 26 months old. And he was born 3 weeks premature. He was delivered immediately after following a domestic violence incident. So there was tons of domestic violence in his home, and even after he was born, but he was actually born right after the domestic violence incident. So they were hypothesizing that some of the high stress may have led to some of the prematurity, but also he was exposed in utero to heroin and cocaine. So that definitely could have had an impact. He experienced some mild withdrawal symptoms, but he didn't require any type of dosing down or medication, and he was not diagnosed with NAS. He was discharged with the biological parents home. So he went home with mom and dad, and CPS did get involved and started some programs with moms, so provided some support for her. Unfortunately, the domestic violence did continue once they returned home. And mom was hospitalized 3 times before she ended up leaving and going to a shelter. So when they came to me, who came to me was mom and the maternal grandmother. So mom's mom and the maternal grandfather. It was a blended family. So the maternal grandfather was actually step grandfather, but they considered him just, the grandfather. And so they came to me. They did great initially. They were really collaborative, wanting to work together to move forward. They were a little resistant in providing all of the information up front. I think, I suspected that mom was possibly either still using substances or or still engaged in the relationship with the biological father that she said she no longer was, because there just seemed to be some disconnect there. So we had some suspicion up front, but that really wasn't what we were focusing on. They came for about 3 weeks straight, and then they missed an appointment. And then they came back, and then they missed 2 appointments in a row. And finally, maternal grandma returned with the patient and shared that mom had overdosed and dad was recently incarcerated. So there was a lot going on. Mom did survive the overdose, but she was in a residential treatment facility. And so they were really excited about that. They did not want Ben to be visiting mom at this time. I've talked with the family about the importance of still keeping that connection and being as age appropriately transparent as they possibly can, but this was a belief of theirs that they did not want him to participate in that. So I did not push it too much, even though I did share my opinion every now and then. At the same time, the paternal grandma had begun to start visitation as well. Now, the maternal grandparents didn't not want her involved, but they were a little concerned with her involvement. They were concerned that she wanted to take custody of the patient, which she did want to, but that did not happen. So there was a lot of resistance, avoidance, some miscommunication. But the presenting problems that they talked about were he wasn't able to focus on one thing for long periods of time. some hyperactivity. They talked about, the paternal grandfather talked about how he just can't keep up with him. He's so active. He became aggressive at times, especially with peers and peers that he enjoyed. And so when he would make friends with somebody, he would quickly lose them because he would just get overly aggressive. Peer relatives, so they had a couple cousins that they would frequently interact with, and he would also become very aggressive with them. The maternal grandma also, they reported that he would stare into space sometimes. So him and her mom initially described this to me, and they did take him to a neurologist, and they ruled out seizures. So he wasn't having any type of seizures, but at times when he was startled or they're not sure what was going on, he would just kind of be daydreaming, is what they said. And he, with a nudge, or if they like snap their fingers or clap their hands, then he would pay attention. So he was quickly brought back, but there were times that he would kind of just stare off. He was startled very easily, loud noises. So there were some sensory concerns, because any loud noise, he would take off and hide. And at first, you know, he would hide in some difficult places. They had a hard time finding him. So, well, the maternal grandfather reported, you know, when he would use power tools, that, you know, he would disappear and then he couldn't find him. So there were a couple times that he was frightened from that. He had a difficult time sleeping. He had a difficult time going to sleep and staying asleep. So that was an issue. He, like I said, he played well with others, but then he would become aggressive. He would never cry or seek comfort when he was upset. He avoided a lot of eye contact at that time. If you talked about something of interest to him, or if you hit something that was very familiar to him, he would definitely look at you and maintain eye contact then. And there were days where he would come in and he would greet me well with eye contact, only after we established a relationship. But frequently he would avoid the eye contact. And they had described him as clumsy. He fell a lot, and he did fall a lot, like even in sessions, especially during transitions, I noticed he would fall. So coming into the room or leaving the room, or if they were getting up and ready to leave, he would fall and become clumsy a lot. So that's the general assessment that I got. Some of the other things that were going on would be, you know, when he was 5 months, he was diagnosed with failure to thrive. There was a lot of domestic violence going on at that time. And that's kind of when CPS started to warn mom that she needs to get away from dad. Dad had left the home at this time, but they were still off and on. So she still maintained custody of him through that, because dad had technically left the home. He wasn't living there. But at 1.5 years, they did take him to their PCP, who diagnosed him with ADHD. They weren't interested in medication at the time, but when they came to talk with me, they were interested in medication, especially because the maternal grandfather was saying, you know, he's just so hyperactive, we need some help. And so, so we looked at providing treatment first. There were referrals made right off the bat for a sleep study, birth to 3, physical therapy and occupational therapy, and those were very helpful. The sleep study was very helpful. He ended up getting his tonsils and adenoids out. He had other, you know, he was snoring, and so that was helpful for some of his sleep, but he still had trouble. So that was helpful for him falling asleep, but he still had trouble at times staying asleep. And I think that was more of his fearful response, because he was just a very fearful child. So just looking at some of that, what do you guys think? Like, where would you go with your differential diagnosis? What kind of approach do you think you would take? Like, where would you start from just that assessment? So my diagnosis is made from pretty much this assessment and then ongoing pieces. And I'll talk a little bit about how I formulate the treatment from that, where we went and where we could have gone. But I'd like to get some of your ideas. Where would you go with a diagnosis for him initially? Anybody?
Foremost, thank you so much, Amanda, for the case presentation and kind of just refreshing everyone's memory on how cases go and everything. We appreciate it. But yeah, we'll just open it up now. Feel free to unmute, speak up, or even chat in. I'll be more than happy to read it out loud.
My first thought went to some trauma reaction with all the symptoms. I also had a question. Can you diagnose ADHD at 1.5?
So,
adult psychologist here, clearly not a child person.
well, I think, you know, there's definitely, I think that's where we come into a lot of difficulty, right? And so we see sometimes, excuse me. I think that's a great question, Colleen. Thank you. But that's where we see some of the overlapping symptoms, right? And so many of the times, I mean, sometimes I've had kids that are like 5 or 6 year old that were diagnosed with bipolar. And I was like, what? So, you know, when you look at development, there's still so much within development and developmental stages. And, you know, if you don't know all of the history or how trauma can impact children, there are so many symptoms that overlap with ADHD and trauma diagnoses. And so I think that that's a really difficult piece when you have parents that are exhausted with some of the hyperactivity, but not really understanding how trauma can impact that. Then when you're looking at some of those signs and symptoms, then absolutely some of those kids can look completely ADHD. But you definitely have to take into perspective the developmental stages they're functioning at, the developmental stages they should be at, and any type of trauma that have impacted them. So great question.
Charity, I noticed you had unmuted. Was there something you wanted to comment on?
I was just looking and wondering, I mean, obviously there's a lot of potential symptoms for PTSD for this individual. I don't know if they would meet full criteria based on the history or not. And age-wise, I felt that was appropriate, but they also sound like they're hitting a lot of attachment issues. And especially with the failure to thrive and things like that happening as well, makes me wonder if there's any reactive attachment symptoms going on for this individual as well.
Yeah, absolutely. Yeah, so I just have to comment first, Charity, is that I always love your backgrounds. So today you have a new background of butterflies and I'm just loving it.
I'm back in the office. I get my butterflies back.
I liked your other one too, so that's why I noticed. So yeah, that's actually, so let me share my PowerPoint. Uh-oh, my host has disabled my sharing participant screen.
See, it might be your other one that you logged.
It's the other, yeah, it's the other one. I have to go, I'm sorry.
No, you're totally fine. Let me know if it works now.
It works, yeah, it works. Okay, let me share this and I'll start from the beginning for you guys. Maybe. My computer is slow. Okay, so yes, so that's exactly where I went. Charity, you hit the nose right, or the nose right on the head. Well, you know what I mean. But you know, I think the one thing when looking at, so first off, he was 26 months old when he came in. When I ended treatment with Ben, he was 6 years old, and we'll talk a little bit about that and some of the barriers that come along with that when working in infant mental health. But I think one of the most difficult pieces with the DSM is there's no real trauma-specific diagnoses except PTSD, right? And so it misses some of those areas. He fell into PTSD, but we have so many kids that don't. So we have so many kids that sometimes, you know, have some of the same experiences as Ben, minus maybe the domestic violence. So really the domestic violence was the incident that made him qualify for the PTSD. But some of the other pieces that fall in line are still very traumatic for kids. And so sometimes that's where those pieces can fall through the cracks within a differential diagnosis. But the nice thing about the DC 0 to 5 is that it does address trauma. And so it has kind of like a catch-all trauma area. And it tells you what to crosswalk it over to. So we'll focus on his diagnosis with the PTSD. So with PTSD, you know, in order for him to meet criteria, he would have to have exposure to trauma, so that cluster A, And then he would have to have at least one of cluster B, which he did. He had some of those dissociative episodes where he would freeze, stand still, stare off. And mom eventually did share. She did start joining treatment after she completed her own treatment. Mom never had full custody of him. She ended up having other children. And it was just, she was involved in his life, very involved, and she remained sober for years. I mean, when I discontinued services with him, she was still sober, and she was a strong participant in his treatment. So she was very involved, but she started to be a little more truthful about some of the experiences that they had. And so she talked about how, you know, when the domestic violence would occur, he would go off into this dissociative kind of episodes. But he never really cried or showed emotions on that. So she always did have some concern. The other criteria is you have to have at least one from C or D. And so he didn't really fit into C, but he did have some in D. He had increased social withdrawal. So he would definitely withdraw from others. The maternal grandma talked about how when biological dad was still in the home that, you know, often Ben did not want to interact with others, including them. And so he would often be off to himself or playing by himself or isolating himself. He was pretty blended in his affect. So he did not have too much positive emotion, and he was very fearful. He also met criteria, so you have to have at least 2 from cluster E, and he did. He had difficulty concentrating. He had that hypervigilance, so he was very hypervigilant of everything going on around him. And this is where sometimes those symptoms of ADHD can come in for trauma kids, because they become very hypervigilant to their surroundings, especially when they've been exposed to trauma or they've had violence within their home, their community. They have to be aware of their surroundings and what's going on. And so they're very much in tuned with noises, and, you know, so it kind of looks like they're all over the place, because they are all over the place at times. And so they have a very difficult time just remaining calm. And he definitely had an exaggerated startle response. I saw somebody put into the chat about if he was tested for sensory issues, and yes, he had very mild sensory issues. But some of the other pieces did not, that kind of made you think that he had full-fledged sensory issues, were just mild, and a lot of them fall hand in hand. So some of the loud noises and some of the startle pieces just were attached to his trauma. He had increased irritability and some anger outbursts. So he did have a hard time dysregulating, but his maternal grandparents were really good with behavioral approaches. And so they had a very positive parenting and behavior approach that allowed him to learn how to regulate and set really effective limits on teaching him how to regulate. And then you also have to have at least one from cluster F, and he did. So he definitely had a disruption within his life, within his routines, his daily activities, his caregivers. And so we'll go through the axes and show you, you know, through infant mental health and the DC 0 to 5, how we really kind of provide that and how that unfolds. You'll see the crosswalk attached here. So it would crosswalk from the DC 0 to 5 to the DSM, the post-traumatic stress disorder for children 6 and younger, and how it does to the ICD-10 too as well. That's the nice thing with the DC 0 to 5 is I don't have to figure that part out. It says it at the end. So all I have to do is identify the diagnoses, and it tells me what it'll crosswalk to. So I usually still provide, because insurance companies don't recognize the DC 0 to 5. So I'll still provide the full assessment within my documentation, but discuss where it crosswalks to, and that's the diagnosis I pulled it under. So the DC 0 to 5, it still goes by the axes, and there's a little difference in the axes. So the axes 1 is the clinical disorder, but axes 2, 4, and 5 are pretty different. 3 is pretty much the same. It's the physical conditions. But when we're looking at axes 2, we're looking at assessing the relational content in the caregiver's levels of adaptiveness and their ability to function. And so we're looking at the infant-child relationship from the caregiver and the environment from the caregiver too. So this is the dimensions that we're assessing within that. And so it helps you go right through it. And this was Ben's. So you can see how it really starts to help you formulate your treatment. So this is where it helps you start to identify where there's a concern, where there's strengths, where you need to come into. So, you know, recognizing emotional needs was a concern. So the caregivers, they had emotional investment. They cared about him. They were interested in him. You know, they loved him, but you know, recognizing some of his emotional needs were a little bit of a concern. They knew he had kind of this blunt affect, but yet they didn't want to do anything about that. They were really avoidant, which caused some concern. And so that's where some of that concern came from. Teaching, there was no concern. They would teach him anything. And when we discussed the needs and where they need to go with that, they were always willing to do that. They were always open. Play was a concern. So they had talked about how they play all the time. But when we sat down to play and assess that, they had a very difficult time playing. So we worked on play. We worked on child-directed interaction, how to increase that positive interaction. His biggest playmate was his maternal grandfather, and he didn't play. He played like a grandfather, right? He played like a grandfather. So he kind of kept a distance. He didn't want to be too involved. He kind of still wanted to do his own thing. And that was a big struggle for this unit, was that they wanted to be grandparents. And you know, towards the end, they ended up giving the paternal grandmother some rights as well, because they realized that they do want to be grandparents. They held a lot of guilt for that, but they weren't. They were primary caregivers. And by that time, mom was more involved too. And so she would take some time to be a caregiver as well. And so they were able to be grandparents, but they felt very guilty about that. And so they worked a lot on that themselves as well. So those were those ambivalent feelings that they were tolerating, not really wanting him as their primary child, but wanting to enjoy him as their grandchild. And so that was a big struggle that we worked on. Disciplining, like I said, was not a concern. I mean, they set very effective limits. Being reflective of their feelings, their emotions, and some of the things that he had went through, that was a little difficult at first. So that was a concern in our initial assessment. So this is the contribution to the relationship. You can see this is what the axes look like, and then this is where Ben's was. He did have some temperament issues, so some dysregulation. His developmental status, he was delayed in some areas, so definitely a concern. His learning, he was pretty sharp, like he picked up on things, but his learning style was a little bit of a concern, because you wouldn't know if he was, or if he was retaining, or he wasn't able to repeat very much back. He was able to repeat conversations, but usually conversations he shouldn't be hearing. And so those were the ones he was really in tune to, right? Which most of our trauma kids are. So this is Ben. This is the caregiving environment. They were able to problem solve really well, all except that avoidance, right? So problem solving was a strength. So we utilized that to overcome some of the avoidance. So you can see where this will map out that treatment for you. Their caregiving role was a concern. They didn't want to be primary caregivers, but they were. And so really overcoming some of that, but they were very much invested. He didn't have any siblings at the time, so there was no need to explore that. Conflict resolution was a concern only, again, because of the avoidance. Many of the times if conflict would come about, they would just avoid it or make excuses for it or move on. And so we definitely talked about that. Caregiving communication became a concern. When mom was in residential, again, it was like out of sight, out of mind. So the maternal grandparents really didn't want to acknowledge that she was in treatment, kind of wanted to avoid that. They really made leaps and bounds with that in separate treatment. So when they worked in recovery treatment with mom, they made leaps and bounds on how they're involved in that recovery process and really accepting that because they were in denial. And that's a stage of recovery. And as a family system, they were involved in that. And so that was a huge piece for them. So overall, we also assess the level of adaptive functioning for these caregivers, and they're strained. So they're at a level 2, they were strained. Compromise would be if there were safety issues continuing to be present in the home, and there wasn't any safety issues that were continuing to be present. The psychosocial stressors are also a little different within infant mental health, and so you can see that he had a lot of psychosocial stressors, and so he had a change in primary caregivers several times, domestic violence, family social isolation. A lot of the times that comes hand in hand with substance use disorder and with domestic violence. And so many of the times families will isolate. Sometimes the perpetrator will isolate individuals so that they don't have that support system to leave. So you see that a lot of the times with domestic violence. Father and mother absence. So at some point, the father's absence was an impact, and then later on, mother's absence was also an incarcerated parent, infant neglect, new adults in his life, trauma, caregiver substance use, unpredictable home life, multiple moves. So he had moved multiple times, including the shelter, but I think before the shelter, they moved twice before that as well. And then when he moved into the maternal grandparents' home. So, I mean, by 26 months, he had moved like 4 or 5 times, which is huge. That has a major impact on children. Food insecurities and child protective service was involved. So you'll see that in Axis 5, this is where you're measuring the developmental competencies. And so we look at different domains. We look at the emotional, the social, relational, language, social, communication, cognitive, and movement and physical development. And so you identify that this is Ben's, but this is where you go through and identify where they should be at their age. So at 26 months, where he should be functioning and where he was falling. And so you could quickly see where, he was definitely not meeting some of those developmental expectations, and there was delay involved. And so emotionally, there was definitely a delay. He was not able to exhibit any type of empathy, embarrassment, pride, and at 24 months, he should be able to do that. Social relationships, those competencies were really inconsistent. He enjoyed being with other kids, but he isolated a whole lot. Some of the other pieces, he was able to imitate others so this was growing and developing. He was starting to imitate other kids, which is what he should be doing at that age, but very fearfully. So he was trying to, but he wasn't responding as appropriately as he should be at 24 months. Language, social, and communication. So he was doing good. He couldn't name actions, but he was really trying to. He would, like I said, he would repeat conversations that he really wasn't supposed to be repeating, but when he was asked to recall or repeat things, he wasn't. And so he was gauging at inconsistent competency at that, but I think that was more fearful. I think a lot of this was more of his fear to respond to some things too. Cognitively, he was inconsistent, but he was a pretty sharp guy. He would complete stories and rhymes. Maternal grandma was shocked one time when I had a book in my office that she happened to have read to him every night before bed, and some nights before bed, and he was able to tell me or repeat like half of the story, and she was like amazed because he never did that before. But this again was only after we had developed more of a relationship. His environment was becoming more stable, and so it was becoming a little more consistent. He could do some 2-step commands, but not many, and so it was really inconsistent for that as well. And then his physical piece, he was really underdeveloped. He had difficulty dressing. He couldn't dress on his own. The tiptoe test, so he would fall if he tried to get on his tiptoes. And we would do an activity where we would pass, just sit on the ground, legs spread, and kind of pass the ball to one another. He had a very difficult time with that. Kickball, couldn't kickball. So we definitely got him involved in some occupational therapy and physical therapy, which helped him. So this was the approach. So we did parent-infant psychotherapy. We addressed the issues of practical and emotional support, providing developmental guidance, anticipatory guidance, so where he should be at his age and how to anticipate any type of behaviors that might come about because he is a little delayed. So how to manage some of that, psychoanalytic informed interpretations of some of the behaviors, what might be going on. So our goal was to foster healthy attachments and reliable experiences. So this was really our approach. And what ended up happening was we achieved those goals. So both maternal and paternal grandparents definitely improved their attachment. They allowed for a distant relationship with mom, but very involved. The consistency of the caregivers became regular. So there was the maternal grandparents, the paternal grandma, and mom, and that became more consistent, which developed healthy relationships. His experiences were more secure, that reduced aggressive behaviors. So we had that reliability, that security, we had that expectancy. So he knew what was coming. He became less fearful. So it reduced some of his anxiety. And he started to not have such a startled response. So he really responded well. And we know that all these gears working together can always help out. But what I started to notice as he got older was that fearful response. And so that fearful response just was so strong, and it stuck with him so much. And so some of the downfalls that I started looking at, because I ended up having to refer him out. And one of the typical downfalls that we come across are, transient caregivers. So having to start over and over again. We started with mom and the maternal grandmother and grandfather. And then mom was out of the picture. So then we had to reconfigure that unit and what that looks like. And we had to start over again. And then the paternal grandma came in. And so then we had to start over again, right? And so you come across some of those downfalls. And so the question could be, did that increase some of that fearfulness and anxiety? I just feel like I missed that as a provider up front. I think we definitely achieved some goals, but this is one of those, those unknown pieces. So there's that ambiguity with cases where you could go in this direction or that direction, and it's all about what you hypothesize and where you go. Not that one area is wrong versus another, but then you think, oh, should I have addressed this first, because would that have helped in this situation? Maybe. Another downfall is the overdoses. So the recovery is a family process. It's a long process. I really think that the family system should have been involved more with mom's recovery. They were later in the game, but I really wish they would have had him involved in, visiting her and still building that relationship. Luckily, they still have a relationship, but that could have been a concern. And with the parent-infant psychotherapy, this is one of the things that always tend to happen is that, I'm sorry if you guys see my dog. My daughter went outside, and my dog, of course, wants to follow. But the parent-infant psychotherapy, what this leads to a lot of the times is that, when I'm working with a family system like Ben's, I start at 26 months, I'm working with the entire system. And that's the best practice approach, right? But then what happens as Ben starts to develop and needs some of those individual tendencies is our relationship changes. And many of the times kids don't trust me because I've worked with the family system. And so they've always seen me refer back to their parents or involve their parents. And I've had a few that insisted on staying with me, and we've talked about how to create those boundaries and what that looks like when I do share information with parents and how I explain that to them first. But a lot of the times I lose that relationship. And so many of the times at that point, I have to refer out. And so he was one that I definitely had to refer out because there were things that he needed to process and explore with his fear that he just did not want me involved because he associated me with his parents or with his, you know, his caregivers. And so that's definitely a downfall that it kind of, it's a bummer because, you know, we all know that when you work with trauma kids, that it's best if they have that consistent provider. And it's just a shame that you get to that point, but it's good as far as seeing them grow and develop and needing that independence on their own. So it's a good piece. So that's my presentation on this case. Any questions or ideas of where you would have went or something that I completely missed that I would love to hear about because I love to grow. So anything?
Thank you so much, Amanda. That was awesome and so so impactful, to be honest. And coming from someone who's not a clinician or anything, it's so eye-opening. Truly appreciate you. Thank you. And Charity was
Just meant to put the picture of the DC 0 to 5. I didn't realize it said buy now, so I apologize. You can't buy it now off my site.
Awesome. No worries. Thank you. And we can keep this up as well so people can kind of note down the references. And I'll for sure include your PowerPoint in the recap email too. But we can keep this up for everyone to take reference of. And Charity, was there something you wanted to ask or comment on?
I was just wondering, for your referral out, were you referring specifically for like some TFCBT treatment or whatever the therapist may have thought, or was there a specific goal you had after when you were finished with the individual?
Yeah, I had shared with the family that I was recommending TFCBT because I really feel like that's where the fear and anxiety, that startle response that he continued to have, that ongoing fear was generated from. And so they understood that. But the TFCBT was, again, they're very avoidant family. So I think it was a little too intense for them. And I think eventually, because I ended up seeing his mom down the road in some family systems pieces, and about a year and a half later, and she said that they were on a wait list for TFCBT. So they were ready for it, but they just weren't ready for it when I recommended. But yeah, that's what I had, exactly what I had recommended. And we had already started hitting some of those pieces from the TFCBT workbook. And he was responding really well to that. But again, it was me as a provider. He just wasn't trusting me to move forward.
And Amanda, we got a chat in asking what the mild sensory impairments were. And they just chatted in a little more information as well. So we can definitely refer to the chat. But Elizabeth, if you wanted to ask the question and unmute, you're more than welcome to as well.
So the mild sensory impairments that I had assessed in the DC 0 to 5, so were just the ones that were being reported to me. So the noises, so the response to the noises and the startle responses. Those were the ones that I had put in that competency list. And so, but when he went for an assessment, they didn't view that as, you know, as an impairment. So I put that as something, and that's definitely something that I put in the infant mental health assessment so that it helps me identify where I, you know, especially when you're working with 5 and under, there's tons of multidisciplinary areas that you have to look at and in coordination, collaboration. And so I always overanalyze that piece so that I'm referring out to the experts that can assess appropriately.
Thank you, Amanda. And Anastasia, I noticed you chatted in also saying the only idea that you can think of is to recommend teaching a clapping or sound pattern for him to respond to instead of using power tool noise to get him to come out of hiding. Thank you for sharing that.
Oh yeah, yeah. So I don't think they didn't use the power tools to get him out of hiding. He would go and hide during that. But I think you mean like when he's staring, doing like clapping, that's what they would do. They would like clap or snap or touch his shoulder. They usually didn't have to get to touching, but they said by the time they would clap or snap. But yes, thank you.
Any other comments, thoughts, or questions from anyone?
If he continued to have continued symptoms or residual symptoms, would you consider EMDR for him?
Yeah, definitely. I think if he was definitely having more trauma-induced symptoms. So one of the things that I did not notice from him was, sometimes there's a fear response and a trauma response to certain situations, right? So from that experience, from that PTSD experience, sometimes certain noises, certain genders, certain approaches would have that same startle response. His didn't seem to be linked to anything. So it didn't seem like it was based off of that trauma. Of course, with younger kids, sometimes we may never know, and they may never really know that true trauma, right? Because of those implicit memories that fire and wire together, they're subconscious. And so they physically feel those things instead of really remembering them. So I think if he had more memories, flashbacks, nightmares, or if he was having a trauma response to a certain situation, individual, tone type, gender, then yeah, absolutely that would have been a recommendation. Good questions.
Thank you so much, Amanda. Anyone else with comments or questions, thoughts, maybe some experiences you've had that you'd like to share with the group?
Amanda, is this the type of case where you could do like a warm handoff to a colleague here for that continued therapy, or do you normally just refer them out?
So it really depends on the availability and the patient location. This patient, they were traveling an hour and a half, and I always try to get patients that are traveling far to go closer to home, because I mean, it's research shows that they're going to be most compliant if it's closer to them and easier to access. And so I really try to, and I was able to link them somewhere closer to home, but we absolutely, it was a warm handoff. We called them ahead of time. We even did, we always do like a ritual. So like a goodbye session, and then I'll do a follow-up session just to make sure they're comfortable with that and that everything's going okay. And so yeah, I always do a warm handoff, especially with trauma kids. Like they just kind of touch my heart. So I always like to check in on them. And I love to hear, I love it when parents will email me like updates of what they're doing. And it's even better when I can do a warm handoff where I'm at, so that I can ask how they're doing and find out. So yeah.
Anyone else? I don't want to cut off the session too short, but I also don't want to keep you guys longer than we have to. Alrighty, well, if there are any other questions for Amanda or just general questions, as always, feel free to shoot me an email. I'll make sure to have them addressed and everything. Thank you so much, Amanda, for the presentation along with that case presentation. So truly appreciate it, and I hope that kind of encourages everyone else also to submit cases. It doesn't have to be a full-on case whatsoever. Just a question in that case form would be absolutely wonderful as well. And I always include those in the recap emails and the reminder emails. So thank you all so much. Our only announcement that we have is our next session will be on March 3rd, and Dr. Swigert is going to be discussing medication management. So keep an eye out for that reminder. We'll see you guys next time. Thank you.
Bye, everybody. Thank you.